All right, today we are diving deep, and I mean deep, inside your blood vessels to watch a microscopic battle that's happening all the time. A construction crew versus a demolition crew in a constant struggle that's literally keeping you alive. We're talking about fibrinolysis. But first, let's kick things off with a question. Think about your body's ability to stop bleeding. It's kind of like the emergency brake in your car, absolutely essential when you need it. But what happens if that brake gets stuck in the on position? A blood clot that overstays its welcome becomes a roadblock, an occlusive thrombus plugging up a critical artery. Well, that's not just a system failure, that is the very definition of a catastrophe. We're talking about things like an ischemic stroke. So before we can talk about tearing down that roadblock, we've got to respect the incredible engineering that went into building it in the first place. So before we meet the demolition team, let's get to know the construction crew. Okay, so how does this whole construction project work? It all starts with an injury to a blood vessel. That's the signal, the call to action. And the first one on the scene is our general contractor, an enzyme called thrombin. Its job is to take all this soluble building material floating around in your blood, called fibrinogen, and convert it into solid strands of fibrin. Think of these as the steel beams of the project. But, a pile of loose beams isn't going to stop a leak. You need to secure them. That's where our specialist comes in, the welder, activated factor 13. It gets to work creating these incredibly strong chemical bonds. Think of them as molecular welds that link all those fibrin strands together into a tough, stable mesh. And just like that, you've got a clot. And this is a perfect example of what happens when just one member of the crew doesn't show up for their shift. There's a rare genetic disorder called congenital factor 13 deficiency, where you're essentially born without that welder. Now, the body can still form an initial clot. The fibrin beams are there. But because they aren't welded together, the whole structure is weak. It just falls apart. So patients have this strange delayed bleeding and really poor wound healing. It just goes to show how every single player in this molecular construction crew is absolutely mission critical. Okay, so the clot did its job, the vessel is patched up, now what? You can't just leave all that scaffolding there, right? Time to clean up and get traffic flowing again. And that's where the hero of our story comes in, fibrinolysis, the body's own elegant, precise, built-in demolition crew. And what's so cool is how perfectly this whole demolition process mirrors the construction. It's got this beautiful symmetry. It all starts when the site supervisor, a protein called tissue plasminogen activator, or TPA, gives the green light. It's released from healthy cells around the clot. TPA then seeks out our demolition expert, a molecule called plasminogen, which is actually already hiding inside the clot just waiting to be activated. TPA flips the switch, turning it into the powerhouse enzyme plasmin. And once plasmin is active, it just gets to work, systematically tearing down that fibrin scaffolding piece by piece. So let's be clear, plasmin is the absolute star of the show here. It's the key player. The best way to think of it is as a pair of molecular scissors. And it's not random, it's specifically designed to get in there and methodically snip apart that cross-linked fibrin polymer. It breaks the whole structure down into these smaller pieces called fibrin degradation products, clearing the way for blood to flow and for the final repairs to be made. Now, you can't just have a super powerful demolition crew running wild, right? You need safety inspectors on site. The body has two main ones. First up is PAI-1, or plasminogen activator inhibitor 1. This one basically puts the brakes on the supervisor, TPA. And this is hugely important in medicine, because PAI-1 levels go up in conditions like obesity and diabetes. That's a big reason why those conditions are so dangerous. They literally cripple your body's ability to clear clots, which puts you at a much higher risk for thrombosis. The second safety inspector is alpha-2 antiplasmin. This one goes straight for the demolition expert itself, neutralizing any free plasmin that might be floating around to make sure we don't accidentally break down a clot we actually need somewhere else. Okay, so now that we've got the natural playbook down, let's talk about how modern medicine has learned to hack the system. Because when a clot becomes life-threatening, doctors don't have time to wait. They have to deploy their own special forces. But before you send in the special forces, you need good intel, right? You need to know if there's even a demolition job to be done. How do they do that? They sift through the rubble. And that is the genius of the D-dimer test. You see, D-dimer is a very, very specific piece of debris. It's a fragment that's only created when plasmin breaks down cross-linked fibrin, the stuff from our welded clot. So if a doctor finds high levels of D-dimer in your blood, it's like finding a specific type of rubble at a demolition site. It's direct proof that a big clot was built and that your body's demolition crew is hard at work trying to tear it down. But here's the thing about that intel. It's not perfect. The D-dimer test is fantastic for ruling out a clot. If the test comes back negative and the doctor wasn't too suspicious to begin with, they can be pretty confident you don't have a dangerous clot like a DVT or a pulmonary embolism. But it's not great for confirming one. Why? Because lots of other things, infection, cancer, even just having surgery, can raise your D-dimer levels and give you a false positive. So a positive D-dimer test isn't a diagnosis. It's a flashing red light that says, hey, we need to get some real pictures, like a CT scan, to see what's actually going on. So when that imaging comes back and confirms there's a life or death blockage, the body's own cleanup crew just isn't fast enough. That's when doctors call in the elite reinforcements, powerful drugs called thrombolytics. These are basically a massive, concentrated dose of the body's own clot-busting activators. And these drugs are basically lab-made, supercharged versions of our own TPA. This table really shows you the evolution here. The first generation, Altiplas, has a super short half-life, just about 5 minutes, so you have to give it as a continuous IV drip. The next ones, like Retiplas, last a bit longer. But the real game changer is Tenectiplas. It lasts even longer, it's way more specific to the fibrin in the clot, so it works where you need it to, and best of all, you can give it as a single, fast push through an IV. It's simpler, it's faster, and for those reasons, a ton of hospitals are making it their go-to drug for strokes. So why all this innovation? Why the push for faster, easier drugs? It all comes down to a single, terrifying phrase that every single person in an emergency room lives and breathes by, especially when it comes to stroke. Time is brain. And this chart right here shows you exactly why this is so critical. A staggering 87% of all strokes are ischemic. They're caused by a clot blocking an artery and starving a part of the brain. For that huge majority of patients, busting that clot is the only shot they have. The other 13% are hemorrhagic, caused by bleeding into the brain. And that's why giving a clot-busting drug without doing a brain scan first would be an absolute catastrophe. And this number is everything. 4.5 hours. The whole emergency response, all the technology, all the training, it all comes down to this one single terrifying number. That is the absolute maximum window from the moment the first symptom appears to when you can give these drugs. After that, the risks just become too great. Every minute that takes by, millions of brain cells are dying. It is a hard, unmovable deadline. And this puts the doctor in an absolutely incredible high-stakes bind. I mean, think about it. The reward is massive. You could restore blood flow, stop permanent brain damage, and literally save someone's life in their future. But the risk is just as huge. You're giving a powerful drug that could cause a catastrophic bleed somewhere else, or worse, turn that ischemic stroke into a fatal hemorrhagic one. It is the ultimate medical tightrope walk. And that's exactly why you can't just give this to everyone with an ischemic stroke. There's a strict safety checklist, a list of absolute no-goes. Did the patient just have major surgery? Are they on blood thinners? Do they have a bleeding disorder? Is their blood pressure through the roof? And number one with a bullet, did that CT scan show any sign of bleeding in the brain? If the answer to any of those is yes, clot busters are off the table. So what happens if you're outside that 4.5-hour window? Or what if you just can't get the drugs? Well, fortunately, the next frontier isn't some far-off dream. It's already here. It's called mechanical thrombectomy. And it's incredible. A specialist actually threads a tiny catheter from an artery, usually in your leg, all the way up into the blocked arteries in your brain. They use a tiny device to grab the clot and physically pull it out. For the right patients with the right kind of clot, this can push that treatment window all the way out to 24 hours. It's amazing. So wow, we've gone all the way from the microscopic world of fibrin strands right up to the high-tech, high-stakes drama of a stroke intervention. We've seen how the body builds, how it demolishes, and how medicine can jump in and hit the accelerator. Which really leaves us with one big question, right? We're getting pretty good at this. So what's the next frontier? What's next in mastering this incredibly delicate life-or-death balance between clotting too much and bleeding too much? That's what scientists are working on as we speak. Thanks for watching.